My name is James Moore. I'm an assistant professor at University of Maryland at the School of Medicine, and I practice pediatric surgery. Most of us would prefer to do something minimally invasive if we feel it was as good as an open procedure, and oftentimes it can be. If you can go and do the same procedure through smaller incisions, the recovery time is quicker, the postoperative pain is a lot better. So it's always something that's preferred if it can be done safely and is as effectively that way. As minimally invasive surgery became prevalent in the adult population, people tried to start doing it in kids, but initially the technology wasn't there as far as the size of the instruments, how small instruments were. But as companies have come up with smaller and smaller instruments, we can do more and more in a child through very small incisions. Technology we have at our disposal, we can really do quite a few complex procedures through small incisions. In fact, I sometimes do some of my procedures robotically, which allows us to even have more degrees of freedom in the abdomen through fairly small incisions. All of us kind of have specific interests. I've recently been building a practice in something called the NUS procedure, which is a procedure for repair of a minimally invasive repair of a pectus excavatum. So I've seen kind of an increase in the number of patients I'm seeing for that problem, as well as carinatum, which is related. It's a chest wall malformation that some children are born with, and then some children develop as they go through their teenage years. And it just is essentially a problem where the cartilages that bridge between your lateral rib margins and your bony sternum overgrow. And as they overgrow, they can either depress the sternum or push it anteriorly. And sometimes that carries a lot of psychologic concern for patients and their families because they're afraid to take their shirt off at the beach or go to the swimming pool. And there are physiologic sequelae from that in severe cases. So being able to kind of fix that and bring a patient's chest wall back to a more normal shape is very gratifying for me and for the patient. A lot of our scheduled cases tend to be straightforward outpatient cases. You can fix a problem, the child's doing well and goes home the next day. But then some of the more complex things you tend to get on call. You get a child that's born that has a hole in their diaphragm, or they're not able to stool properly because they don't have appropriate innervation of their intestines, and those types of things. To be able to repair those and get a child back to normalcy is something that we all enjoy on a daily basis.